All right. Good morning, everyone. I am so excited to get started in just a few minutes. If you don't mind, if you're just joining us, please feel free to open up your chat box and say where you are logging in from and a hello. Happy New Year to each of you. We are also live streaming on Facebook as well as YouTube. So please make sure you share this link that I'm just going to be putting in the chat box to all of your classmates or social media accounts, just so that everybody can tune in all together for this high yield live session. We're going to be getting started, but if you don't mind opening up your chat box and saying hello and where you're logging in from, that would be absolutely greatly appreciated. Thanks so much. All right, we have Ahmed from Minnesota, Anu from India, Jay from Chicago, Lanre from New York City. Excellent. Ariana's coming to us from Houston. Thank you all so much for joining. We have a lot of people coming into the classroom. So if you're just joining us, thank you again for joining this high yield webinar. I am so excited to get started in just a few minutes, but if you don't mind, if you're just coming into the classroom, please go ahead and type in hello into the chat box, as well as where you're logging in from. We have an international audience as per usual. We'll get started in just a few minutes. All right, we have Zara from Bahrain, Karen from Guyana. That is absolutely awesome. I can't believe we have such an international audience. We are just coming up on the hour, and I want to thank each and every one of you for joining today. If you can hear me and see me, do you mind going ahead and putting yes into the chat box, please? All right. Looks like we have a lot of people who can hear me and see me. Thank you so much for confirming that. Let's go ahead and get started with our high yield review today. Today, we are going to be covering the top images that you will see on your USMLE Step 1. And we're going to have our focus today on cardiology. So moving a little bit further into this presentation, if this is your first time coming to my webinars, I want to warmly welcome you. And if you're returning Thank you so much for being a part of the HyGuru family. For those of you who don't know me, my name is Rahul, and I'm currently finishing up my pediatric critical care fellowship. And over the past few years, I've been absolutely passionate about helping students just like you prepare for and excel on the USMLE. Here is my contact information. If you have any questions throughout your preparation or want to inquire more about some of the services which I have to offer, also feel free to connect with me on social media. Most importantly, to each and every one of you, as we start our webinar today, I want to wish you a very warm, happy new year. I hope this new year 2022 brings you the best in health, happiness, and studying success. So before we get started in our presentation today, I do want to spend just a few minutes kind of talking a little bit about what makes HyGuru unique. I know there are so many resources out there already. As many of you know, HyGuru is an evidence-based approach to USMLE preparation. I specifically, in all of my lectures and in all of my courses, focus on active recall, making sure that you are learning the application of various concepts that you are studying from other resources. I like to integrate material together from various domains and various organ systems. And most importantly, I like to provide students with some key test-taking strategies that will make them very successful on exam day and on NBME practice exams. Now, when it comes to my preparation methodology, as well as all the courses which I've developed, I really focus on this content integration and test-taking strategy, along with making sure that you are productive and have a peak performance mindset. And so I really have been so blessed throughout the years to really create a USMLE family. And I've been humbled and blessed to teach live in person at top tier medical schools. And now we are a global community of lifelong learners in medicine. And I'm so excited that you are here today to join me in this review. Now, in case you missed it, last week, I did release my very innovative and brand new USMLE Step 1 Pass-Fail course. Make sure you go to HyGuru.com and sign up for this course, especially if you are gearing up to take your exam before or definitely after the January 26th pass-fail deadline. So yesterday, in addition to the pass-fail course, which I released last week, yesterday, I released a brand new course that I am going to talk a little bit more about at the end of this webinar, but I do want to let each and every one of you know that I just released my study schedule, productivity, and test-taking strategies for the USMLE course. This course brings one-on-one tutoring to the comfort of your own study space, and it gives you a study plan as well as unique videos on how to approach various question types on the USMLE. And again, this is found on HyGuru.com and more to come at the end of this webinar. So before I go into those specific courses and answer your questions, I do want to make sure that we are focused and get through our session today, which covers the high yield images and physical exam findings for your USMLE Step 1 as it relates to cardiology. I do want to give you one disclaimer. And that is, over the next hour, please make sure that you are staying focused with me, opening up the chat box and engaging with me. Cut out all distractions, put away your phone, turn off those browsers that you don't need. I want you to just focus with me because this session is going to be very high yield for your preparation. Most importantly, I will be doing a live Q&A at the end of this webinar. So make sure you either type your questions as we go or save them until the end. So if you guys are ready to get started, go ahead and type in yes into the chat box. Is everybody ready? Awesome. We have over 100 people joining us. Excellent. Facebook, YouTube. All right. Thank you all so much for your attention. Let's go ahead and get started. Remember that this series of webinars tackles the image-based questions that you will see on the USMLE Step 1. If you missed the introduction session last weekend, I highly encourage you to check it out because I give you an insight as to how NBME question writers test and write these image-based questions. So today we're going to have gross pathology, microscopic pathology, some radiology. I even put some echoes for us to look at as it relates to cardiology, and we'll be integrating content throughout the session. So when it comes to cardiology, here are the high-yield images and physical exam features. We're going to be covering maneuvers and murmurs, specifically what makes murmurs louder and softer. We're going to be talking a little bit about heart failure and going through JVD as well as mechanisms of edema. We're going to be talking about structural heart issues such as hypertrophic obstructive cardiomyopathy, Tetralogy of Fallot. We're going to be looking at the radiographic findings related to coarctation of the aorta. We're going to also be talking about rheumatic fever and how rheumatic fever causes you to have a pancarditis. And then finally, we will be going through bacterial endocarditis and the various physical exam features you will see. So let's go ahead and get started with our first topic today, and that is covering murmurs and maneuvers. Our first question: an 80-year-old male presents with shortness of breath and fatigue. The patient was brought into the emergency department last week due to lightheadedness during activity. The patient is noted to have a harsh ejection type murmur at the base of the heart radiating to the neck. Given this murmur, which additional finding may be seen in this patient? A, S3, B, S4, C, recurrent streptococcal infections, D, myxomatous valve degeneration due to prolapse. What do you all think the answer is here? All right, we have a couple answers coming into the chat box. If you are saying S4, you're absolutely correct. Now, this patient has syncope, angina, dyspnea, which is very characteristic of aortic stenosis. This harsh ejection type murmur at the base of the heart, remember that the base of the heart is at the top. This is basically going to be the murmur of aortic stenosis. And whenever you have aortic stenosis, here's the pathophysiology as to what happens. Here is the left ventricle. Here is the aorta. As you have stenosis, the left ventricle undergoes an increased amount of stress, increased myocardial oxygen demand, increased amounts of afterload. These are all mechanisms that you will see on your exam. And over time, the actual cells undergo hypertrophy. And as they undergo hypertrophy, the myocyte fibers on gross pathology will be arranged in parallel. And so whenever you have the atria that is going to empty into a very, very hypertrophied or non-compliant, very stiff ventricle, whenever the aorta is going to contract into a very stiff, non-compliant ventricle, you will see S4. And so relate S4 to chronic hypertension, as well as your aortic stenosis. All right, very good. So let's go ahead and use this question to go into a very important test taking strategy. And that is, how do I approach murmurs on the USMLE? Well, I like to take a page out of the book of real estate when it comes to murmurs. And I always focus on where the murmur is heard. So I look in the physical exam sentence in the vignette and I say location, location, location. So let's go ahead and go through the auscultation locations. So remember that this is going to be where we put the stethoscope on the patient and figure out what kind of valve is messed up. So if you have the right second intercostal space at the peristernal border, that's going to be the aortic valve. If you're talking about the left intercostal space at the peristernal border, you are going to be thinking about the pulmonic valve. If you're thinking, for example, of the apex at the mid-clavicular line, you are going to be thinking about the mitral valve. So what we have to recognize here is that USMLE questions will give you where exactly the murmur is heard. So if you hear a systolic murmur at the right second intercostal space at the peristernal border, you can only have two options. It's aortic regurg or aortic stenosis. And in the case of a systolic murmur, that's going to be aortic stenosis. Another USMLE question, which you're going to get, is a multimedia question in which you will have to click with your mouse the specific auscultation points and try to think of a murmur. You will hear the murmur at a specific auscultation point as you click on their multimedia image. And so once you click on, for example, the pulmonic valve and you hear a murmur, you will then go down the path of discerning whether or not it's a pulmonic stenosis or pulmonic regurgitation murmur. So moving forward, I do want to kind of synthesize this test taking approach and build on it. So when it comes to test taking approach to murmurs, first I said, localize that auscultation point in your USMLE question. The next thing you need to do is discern whether or not it's a systolic murmur or a diastolic murmur. Remember, systolic murmurs are going to be heard between S1, which is the closure of the mitral valve, and S2, which is the closure of the aortic valve. So a systolic murmur is going to be heard between S1 and S2, between the lub and the dub. What you also have to do afterwards, after you localize the auscultation point, after you characterize systolic versus diastolic, is you have to understand what maneuvers are going to make this louder or what maneuvers are going to make this softer. And we're going to be focusing on the louder aspects of things. So whenever I try to discern whether or not a murmur is systolic or diastolic, I always go back to normal cardiac physiology. And if you haven't seen my cardiac physiology YouTube video, please make sure you check that out. So when it comes to discerning whether you're talking about a systolic or diastolic murmur, I always go back to normal physiology and ask myself, what valve should be open and what valve should be closed? And if any issues are at that valve, it will cause a murmur, because a murmur is basically turbulence across a defective valve. So for example, when you're thinking about the left side of the heart and systole, in systole, what valve should normally be open? Go ahead and put that in the chat. In systole, what valve normally should be open? Go ahead and put that into the chat if you're thinking about the left side of the heart. Okay. So if you said in systole, aortic valve is going to be open, you're absolutely correct. So if there is stenosis of the aortic valve, you will hear that in systole because the aortic valve is supposed to be open in systole. Now, what valve should be closed? The mitral valve in systole should be closed. So if there is an issue where the mitral valve is open, that is pathology. And so a systolic murmur, along with the aortic stenosis, is mitral regurgitation. And how do you tell the difference? Well, it's usually going to be based on location. So let's go ahead and synthesize this. Systolic murmurs are going to be things like aortic stenosis, mitral regurgitation. You're going to have VSDs. Those are usually going to be holosystolic murmurs, heard best at the lower peristernal border. You're going to have mitral valve prolapse, which is going to be heard at the apex. And remember, that comes with a mid-systolic click. And you're going to be thinking of hypertrophic obstructive cardiomyopathy. And the murmur that you will hear is going to represent the dynamic left ventricular outflow tract obstruction that you will see with the hypertrophied interventricular septum as it hits against the free left ventricular wall. When you're talking about diastolic murmurs, you are going to be thinking about aortic regurgitation, mitral stenosis, which is going to be related to rheumatic fever. We'll talk about that upcoming towards the end of the webinar. We're also going to be thinking about the opening snap that you will hear with mitral stenosis. And then finally, one that I put that is very high yield for your exams is the tumor plop of a intraatrial mass, such as a myxoma or a cardiac rhabdomyoma. Remember that during diastole, these masses will create a ball valve effect on the mitral valve, for example. Now, what's going to be a murmur that is going to be heard throughout systole and diastole? Go ahead and put that in the chat. What murmur can be here continuous throughout systole and diastole? Go ahead and put that in the chat and hint it is going to be a congenital heart lesion. Awesome. If you said PDA, you are absolutely correct. And remember that we want to keep the PDA open in certain situations, especially cyanotic heart lesions with prostaglandin. So remember, PGE2 keeps the PDA open. So let's go ahead and review our test taking strategy, localize the auscultation point on your exam, characterize systolic versus diastolic, and next we're going to be talking about the maneuvers. So this is relatively, at first glance, a very overwhelming chart, but I'm going to break it down for you. Remember that when it comes to murmurs, the basic framework is murmurs are basically turbulence of blood surrounding a valve. So you are going to have maneuvers that are either going to cause increased blood flow across the valve or decreased blood flow across the valve that will make a murmur louder or softer. I'm going to go ahead and focus a little bit on the louder side of things. So when it comes to increasing blood flow in the heart, you are going to have preload maneuvers as well as afterload maneuvers. So your preload maneuvers are going to be the gravitational effects of leg raising, as well as the compression of veins that you will see with squatting and the blood just coming back to the heart when you are squatting. So leg raise and squatting increase preload. When it comes to decreasing preload, you're going to be thinking about the Valsalva maneuver, in which you have a positive intrathoracic pressure that causes you to have reduced venous return, i.e. reduced amount of preload, because your intrathoracic pressure is super positive. And that means that your right atrial pressure is very positive, and the caval blood cannot go into the right atrium, and thus you have decreased amounts of preload. Next, you are going to be talking about afterload maneuvers. Now, when it comes to afterload maneuvers, think about making your aorta either very tight or making your aorta very loose. So when you're making the aorta very loose, you are going to decrease afterload, i.e. decrease the resistance that is going to be at the aorta itself. When you're going to be decreasing afterload, you're going to be thinking about maneuvers such as giving nitrates or maybe giving an opioid that vasodilates. When you're thinking about increasing afterload, you are going to be thinking about hand grip, because you have increased amounts of resistance that is transmitted from the brachial arteries all the way to the root of your aorta. And this is going to be very important, that hand grip increases afterload. So let's go ahead and go through now the preload side of things. When we go through the preload side of things, we definitely need to understand that when it comes to aortic stenosis, mitral stenosis, aortic regurg, and mitral regurg, having more blood in the heart is going to make these murmurs very loud. So whenever you increase preload via leg raise or squatting, you are going to increase the intensity because more blood is going to be flowing across those abnormal valves. And remember, murmurs just represent turbulent blood flow across an abnormal valve. Now, there are two murmurs that actually increase in intensity with decreased preload, and that is going to be hypertrophic obstructive cardiomyopathy and mitral valve prolapse. The summary point for HOCM and MVP is the fact that when the heart is empty, you will hear the murmur the loudest. When the heart is empty, you will hear the click of mitral valve prolapse much earlier. Let's go ahead and talk about the afterload side. When it comes to the afterload side, we are going to be characterizing the murmurs as forward flow or backwards flow. So what does this all mean? Well, remember that regurgitant murmurs are going to be backward flow murmurs. So things like aortic regurgitation, mitral regurgitation, those are going to be backward flow murmurs because you're going, for example, an aortic regurgitation from the aorta back into the LV. So anytime you are going to increase your afterload and make the aorta very, very tight, that blood is going to regurgitate more from the aorta back to the left ventricle. And so that's why when you're talking about backward flow murmurs, they are going to increase in intensity when you increase the afterload. High yield for us to know, just as a summary point, is that when it comes to preload maneuvers, the two murmurs which prefer an empty heart, i.e. are louder with an empty heart, are HOCM and mitral valve prolapse. So I would say what is high yield is this, and this. Okay. All right. Very good. Let's go ahead and apply this strategy. But if you're following along with me and you're enjoying this review, go ahead and type in yes into the chat box, please. So I know you are paying attention. Awesome. Moshe, Ahmed, Ariana, Fanishka. Excellent. Yami, thank you so much. So let's go through this very high yield question. 80-year-old male with a decrescendo systolic murmur that increases with expiration. He has a history of chest pain and shortness of breath. Now he presents after passing out. His murmur is heard best at the right second intercostal space with radiation to the carotid. What feature may correlate to increased severity of this murmur? So when it comes to this murmur, I first want to put into you, I want you to put into the chat box, what kind of murmur are we dealing with right now? Go ahead and put that into the chat box. If you said aortic stenosis, you're absolutely correct because it's a right second intercostal space, and you are going to be thinking of a systolic murmur at that aortic side, and that is the aortic stenosis. Now, whenever you have a longer and later peak of the murmur, that correlates with an increased intensity of the murmur and relates to a higher LV to aorta pressure gradient. Whenever you have this longer, later peak of the murmur, that determines the degree of aortic stenosis. And especially when you have low cerebral blood flow, i.e. patients are going to have syncope because the LV can't pump that blood into the carotid circulation and into the brain. This is when we say, hey, this is severe aortic stenosis. We need to consider actually replacing the valve. So what if this patient was a middle-aged male on your USMLE with aortic stenosis? What would be the likely pathophysiologic mechanism here? And if you're going to be thinking of bicuspid aortic valve in middle-aged males with aortic stenosis that's premature, you are absolutely correct. Remember, bicuspid aortic valve seen in Turner syndrome, also seen de novo in middle-aged males, can predispose you to early onset aortic stenosis. So what is bicuspid aortic valve? Well, if you look at this very nice tri-leaflet of the normal aortic valve, you have 1, 2, and 3. When you're talking about a bicuspid aortic valve, you only have 2 leaflets. And that is going to be the distinction. And again, this predisposes you to premature aortic stenosis. Let's go through this question. A patient presents due to syncope. He has no history of trauma and is otherwise healthy. The patient has a harsh systolic murmur heard throughout the precordium. Lungs are clear and there are no signs of JVD or pitting edema. An echo shows interventricular septal enlargement and low ejection fraction. What is the likely mechanism behind this patient's reduced cardiac output? A, aortic valve cusp increasing size of the left ventricular outflow tract. B, aortic valve dilatation and blood in the intimal layer of the aorta. C, calcified fused aortic valve leaflets. or D, mitral leaflet obstructing left ventricular outflow tract? What do you all think is the answer here? All right. So this physical exam description is going to represent the hypertrophy of the interventricular septum, and that is very characteristic of hypertrophic obstructive cardiomyopathy, in which the anterior leaflet of the mitral valve is going to hit against the hypertrophied interventricular septum and cause you to have an obstructive left ventricular outflow tract. So let's go ahead and build on this question by going through this multiple choice question. A patient dies of ventricular arrhythmia. Post-mortem autopsy shows an abnormal interventricular septum. This abnormal interventricular septum is 3 times as thick as the normal interventricular septum. A genetic analysis of this gross pathological finding would likely show which of the following abnormalities? A, infiltrative disease due to sarcoid. B, genetically mutated potassium channels. C, granulomatous inflammation of the myocardium. Or D, genetically abnormal myocardial muscle proteins. What do you all think is the answer here? Excellent. If you said D, you are absolutely correct. Genetically abnormal myocardial muscle proteins is going to be the pathophysiologic mechanism behind hypertrophic obstructive cardiomyopathy. So when it comes to HOCM, what is the micropathological finding for HOCM? Just as a spaced repetition, it is going to be myofiber disarray. And I'm going to show you a picture of that in the next slide. What is the likely genetic mutation behind this myofiber, disarray? And that is going to be the abnormal cardiac sarcomere proteins. Remember, the sarcomere is going to be made up of actin, myosin, and T tubules. These patients are specifically going to have a beta myosin heavy chain mutation. Now, when it comes to hypertrophic obstructive cardiomyopathy, these patients are going to have diastolic dysfunction because they're going to have a very non-compliant LV, and they're going to have mitral regurgitation secondary to the anterior motion of the anterior leaflet of the mitral valve. You can see that the mitral valve is basically going to be very incompetent because of the hypertrophied interventricular septum. Also, what you have to recognize is that these patients on your exam are going to have sudden cardiac death because of the abnormal structural makeup of their heart that then is going to affect the electrical activity of the heart. So what we have to recognize is that these patients are going to have high diastolic pressures, and their LV EDP, which is their left ventricular end diastolic pressure, is going to be very high because the left ventricle, due to the hypertrophied interventricular septum, is going to be very, very stiff and non-compliant. It's not going to fill as well. So if I ask you what physical exam maneuvers increase the intensity of the HOCM murmur, go ahead and put into the chat what physical exam maneuvers would increase the intensity of this murmur. Okay. Excellent. If you're saying Valsalva, you're absolutely correct that maneuvers that decrease preload, such as standing, as well as Valsalva. Remember, from a physiology standpoint, standing is going to cause you to have a decreased venous return because of the gravitational effects of standing. All that blood is going to pool into the venous circulation. And remember that the venous circulation, just as a physiology integration, has high capacitance. It has a high ability to hold a lot of blood. So let's go through some high yield images that you'll see on your exam. This is going to represent the myofiber disarray in hypertrophic cardiomyopathy. This is going to represent a gross pathology of the hypertrophied interventricular septum. Here's the anterior leaflet of the mitral valve, which causes the LVOT obstruction, as well as can be incompetent, i.e. have mitral regurgitation in hypertrophic cardiomyopathy. And remember that you have this decreased cardiac output due to the anterior mitral valve leaflet obstructing blood flow as blood is going from the LV into the aorta. All right, let's go ahead and transition to our next topic, and that is going to be physical exam features of heart failure that you will see on your USMLE. All right, let's go through this question. A 50-year-old obese male with history of smoking presents with increased shortness of breath and exam showing rales with pitting edema. The patient is also noted to have the following physical exam finding. So here is the physical exam finding. On echo, he is noted to have a low ejection fraction. What is the likely murmur heard on physical exam? So clearly, this patient is going to have left-sided heart failure. The patient is going to have rales, signs of fluid overload, and this classic physical exam finding of JVD. And so when it comes to the murmur, which you may hear in a patient who has congestive heart failure, it is going to be an early diastolic murmur known as the S3. Remember that the S3 represents the left atrium filling into a very dilated left ventricle, because in congestive heart failure, your LV becomes just a very floppy bag. So here is a very nice Venn diagram that kind of helps you discern right heart failure from left heart failure. Now, remember that when it comes to the most common cause of right heart failure, it is usually going to be left heart failure. So when it comes to left heart failure that we saw in the question, blood is backing up from the left ventricle into left atrium and then is going to flood the pulmonary vasculature, causing you to have increased pulmonary edema. That blood is then going to go into the right ventricle, right atrium, and you're going to have raised jugular venous pressures. You're going to have pitting edema, and you may even have some hepatomegaly. Patients who are going to have right-sided heart failure, though, are going to characteristically have clear lungs. And this is really, really important, because remember, if you think about flow, if you have right heart failure, isolated right heart failure, in the absence of left heart failure, if you have isolated right heart failure, say from pulmonary hypertension, fibromuscular dysplasia, etc., you are going to have blood that is going to back up from the RV to the RA, causing raised jugular venous pressures, hepatomegaly, subsequent ascites, as well as pitting peripheral edema. So the major difference is that left heart failure has crackles on the physical exam in your USMLE questions. So let's discern and go through the pathophysiology of right heart failure in a little bit more detail. Remember that you have right ventricular dilation and hypertrophy. So your RV becomes very, very sick. Why? Because sometimes the pulmonary valve is going to be very stenosed, or the patient is going to have increased pulmonary vascular resistance. And if your pulmonary vascular resistance, PVR, is going to be very elevated, your RV is going to have increased amounts of afterload and can't get that blood into the pulmonary artery. So where does all that blood go? Well, all that blood backs up into the right atrium. And so, just as a side note, patients who have pulmonary hypertension on your USMLE, they might say, hey, the patient has tricuspid regurgitation. And that tricuspid regurgitation represents all of that blood going from right ventricle across the tricuspid valve and into the right atrium. Now, whenever you have blood backing up on that right side, you're going to have increased jugular venous pressure and increased central venous pressures. Patients are also going to have this congestive hepatomegaly because now you are going to have blood backing up into the IVC and the hepatic vein. Patients are also going to have ascites because now your splanchnic or portal circulation is going to have increased amounts of blood that is going to extravasate into the peritoneum. And then finally, patients are going to have increased hydrostatic pressures in their lower extremities, and that is known as pedal or pitting edema. So Remember that when it comes to left heart failure, that there are going to be crackles on the physical exam. So left heart failure, I'm going to illustrate in blue that your LV is going to be failing. And that's why all the blood is going to then pool into the lungs. And so that's why left heart failure, you can see this very characteristic image, which is going to be the alveoli that are going to be filled up with this very transudative fluid. And that integrates some gen path that when you're talking about transudative fluid, that is usually due to hydrostatic forces. And in this case, in left heart failure, LV backs up into the LA, that backs up into the pulmonary veins, backs up into the pulmonary capillaries. You have increased hydrostatic pressure due to that congestion. And subsequently, your alveoli are going to be flooded with non-protein rich transudative fluid. Now, going back to either left heart failure that's very severe or isolated right heart failure, these patients are going to have that congestive hepatomegaly. And you can get a gross pathology image on your USMLE that is going to be known as the nutmeg liver. And that is essentially going to be centrolobular necrosis that is going to be congested by blood. And you see a nutmeg type appearance on your liver just due to the passive venous congestion. So let's go ahead and go through this question. A patient presents to the ICU with heart failure exacerbation. He has chronic kidney disease and hypertension. Despite aggressive resuscitation, the patient unfortunately passes away. Autopsy shows alveolar cells containing increased amount of golden brown cytoplasmic granules that stain iron positive. Which of the following mechanisms is associated with this autopsy finding? A pulmonary embolism, B, LV ejection fraction of 30%, C, pneumoconiosis, or D, airway hyperreactivity. What do you all think the answer is? Go ahead and put that into the chat box. Excellent. If you said LV ejection fraction of 30%, you are absolutely correct. Remember, the blood is backing up and causing those heart failure cells or those hemosiderin-laden macrophages. So I wanted to go through some gen path integration. And this is directly from my USMLE pass-fail course that goes through in a very active recall way, chapters 1 through 3 of Pathoma and the high-yield gen path concepts. When it comes to transudative fluid, this is due to a disturbance of hydrostatic forces. These patients are going to have low pleural protein, low pleural LDH, which is a non-specific marker of cell injury. Common causes of transudative effusions are going to be hypoalbuminemia as well as congestive heart failure. Switching gears, when we talk about exudative fluids or exudative effusion, think about extra protein due to inflammation. These patients are going to have a high pleural protein and a high LDH, and common causes are going to be things like infection, malignancy. For example, you're going to be thinking of mesothelioma, infections such as tuberculosis, and even pulmonary embolisms can cause you to have a lot of inflammation and subsequently exudative fluids. So just for a step 2 CK point, and I'm going to be covering step 2 CK in the coming months, but Light's criteria is highly tested on the USMLE step 2 CK, and that helps you discern whether the pleural fluid you have is transudative versus exudative. So let's just go through some physiology integrations. And I want to talk to you about edema. Remember that if you're talking about normal vascular physiology, you have blood that goes into our arterial, into a capillary bed, is filtered out into the tissues where nutrient exchange occurs, and you have at the venule side some reabsorption of the fluid. This is the same thing that happens, for example, in the Bowman space, if you're going to try to integrate some concepts, that you have afferent arterial, the glomerular tough capillaries, and then the efferent arterial. Whenever you're going to have increased hydrostatic forces, that's going to cause the fluid to flux out of the capillary bed. And the oncotic pressures are going to pull the fluid back in because the oncotic pressure is usually derived from intravascular proteins like albumin. So whenever you have edema, you are going to think of the framework that, oh, either I have increased hydrostatic pressure, either I have low oncotic pressure, so the fluid cannot be pulled back, or I have some sort of lymphatic obstruction. So let's go through some USMLE questions. Increased hydrostatic pressure, that's due to maybe fluid overload. We talked about the chronic passive congestion that you will get at the level of your pulmonary veins, especially when you have left heart failure. Low oncotic pressure, think about patients who have nephrotic syndrome. They're peeing out a lot of proteins, or patients who have burns, for example. And lymphatic obstruction. A classic USMLE question is somebody who is going to get a sentinel node biopsy for breast cancer, for example. You disrupt the lymphatics, and subsequently you have chronic lymphedema of your arm because you have obstructed your lymphatics during your sentinel node biopsy. So what we have to recognize is that patients who are going to have edema, how are they going to present on the USMLE? So let's get it back to the left heart failure because we're talking about cardiology. Patients can have pitting edema, and that just represents that you have increased hydrostatic pressure and all of that blood backing up in the lower extremities. And patients are going to have pleural effusions. And if I asked you in left heart failure, are the pleural effusions transudative or exudative? Go ahead and put that into the chat. Are pleural effusions in left heart failure transudative or exudative? What do you all think? Excellent. Everybody should be answering. You're absolutely correct if you said transudative. And so what we have to recognize here is that when it comes to recognizing pleural effusions, you want to look at that costophrenic angle where the diaphragm and the base of the lungs are going to meet. And if there is a hazy opacity there, you're likely going to be dealing with some fluid right at that area. And so typically patients who are going to have left heart failure are going to have bilateral pleural effusions on your chest x-ray. Speaking of chest x-rays, let's go ahead and talk about our next topic, which is going to be x-rays of cardiac lesions. If you guys are enjoying this webinar thus far, go ahead and type in yes into the chat box so I know you are paying attention. Excellent. Thank you guys so much for sticking with me. Let's go through our next section, which is the x-rays of cardiac lesions. The first thing that I'm going to be talking about here is Turner syndrome. I'm going to integrate, just like my syndromes webinar, all of the things you need to know for Turner syndrome, and I'm going to relate cardiology very heavily. Remember that Turner syndrome is due to non-disjunction during meiosis, and you get this 45XO genotype. What are some characteristic physical exam findings that you'll see? Well, you're going to be seeing the short stature, the high arched palate, webbed neck, and the shield chest. The cardiac manifestations of Turner syndrome is going to be bicuspid aortic valve, as well as coarctation of the aorta. What about the extremity changes that you'll see in Turner syndrome? Lymphedema, as well as osteoporosis. Now, these patients may have inherently weak bones, or it's because of the reproductive time. That's why they have the osteoporosis. And remember that these patients have those streak ovaries. So they're going to have hypergonadotrophic hypogonadism. Their gonads don't work. So their tropic hormones, the hormones that are going to be coming from the hypothalamus and the pituitary, are going to be elevated. And then finally, remember, because these patients are going to have those streak ovaries, they can have infertility, or on your USMLE, they'll present with not having a period by the age of 16. So let's go ahead and just focus a little bit on the cardiac manifestations of Turner syndrome. When it comes to coarctation of the aorta, remember that these patients likely are going to have a preductal coarctation, and because they have a narrowing, just like a hose that is kinked, because they have a narrowing of their aorta, their intercostal arteries, which branch from the aorta, are going to be very, very engorged. And that is going to abut the cartilage that runs at the inferior portion of each rib. And so that is the mechanism behind rib notching with coarctation of the aorta. Remember that the anatomic tie-in here is that the nerve, artery, vein of the intercostals of the ribs are going to go underneath the rib. And so there's cartilage, and then you have your nerve, vein, artery, etc. So when you have engorged intercostal arteries, it's going to start chewing into that cartilage at the inferior portion of the rib, and that's what gives you the rib notching. So what I want to do now is go through a quick rapid review of genetic heart lesions and the specific cardiac anomalies you will see on your USMLE exam. So let's go through this. Down syndrome. What are going to be the key characteristics in Down syndrome? Well, you're going to have endocardial cushion defects. And remember that those endocardial cushion defects are going to give you regurgitant atrioventricular valves. What about DiGeorge syndrome? What are patients going to have? Tetralogy of Fallot. What about Friedreich's ataxia? These patients are going to have issues with gait on your exam. They're going to have diabetes, peripheral neuropathy. They're going to have trinucleotide repeats, and you're going to be thinking of hypertrophic cardiomyopathy. What about Cartaginer syndrome, in which your cilia don't work? These patients are going to have issues with their sinuses, recurrent lung infections or bronchiectasis, and they're going to have situs inversus. The heart's going to be on the other side, on that right side. What about Marfan syndrome? Remember that in Marfan syndrome, they're going to have bad fibrillin. So their vessels are going to not be as strong. And subsequently, they can get mitral valve prolapse, but specifically, they can get aortic aneurysms. What about tuberous sclerosis? Well, we alluded to it a little bit. We're going to be thinking about those cardiac rhabdomyomas, the tumor plop. And then finally, Turner syndrome, we just talked about it, aortic coarctation and bicuspid aortic valve. And what murmur is associated with bicuspid aortic valve? Go ahead and put that into the chat box. What murmur is going to be associated with bicuspid aortic valve? Excellent. I'm seeing aortic stenosis. Yes, you're absolutely correct. Aortic regurg can be as well. And so you are absolutely correct that these aortic abnormalities. All right. So let's go through this application question. A neonate with seizures, secondary to hypocalcemia and recurrent fungal infections. A genetic etiology is suspected. What is the likely cardiac lesion associated with this genetic etiology? So go ahead and look through this. The patient has hypocalcemia, recurrent fungal infections. If you're thinking about DiGeorge syndrome, you're absolutely correct that patients with DiGeorge syndrome can have this conotruncal cardiac defect. So they can have tetralogy of Fallot, truncus arteriosus. They can even have an interrupted aortic arch. And that's because embryologically, just to tie that in, the conotruncal septum is going to be abnormal in these patients with the 22q11 deletion. So let's go through tetralogy of Fallot. When it comes to tetralogy of Fallot, remember that you have this embryological mechanism in which you have failure of the neural crest cells, which makes the actual conotruncal septum, the failure of neural crest cells to migrate, and thus you get an overriding aorta. That overriding aorta then pushes into, as it overrides, as it moves, it pushes into the pulmonary valve in the right ventricular outflow tract. And so patients can get pulmonic stenosis. Subsequently, patients are going to get an exposed ventricular septal defect because the aorta itself shifted to the right side. So behind, you will have a VSD that is exposed. And because you have chronic right ventricular outflow tract obstruction due to pulmonary stenosis, you're going to get over time right ventricular hypertrophy. And subsequently, that RV pressures, their right ventricular hypertrophy, the right ventricular pressures are going to be so high that it will shunt blue blood to the left side. And that's why you can get hypoxemia. So why do you get cyanosis in tetralogy of Fallot? Well, you can get it because of the pulmonary valve stenosis. and the fact that blood can't go from the right ventricle into the pulmonary arteries, and that causes you to have low perfusion in your pulmonary arteries. And so that is going to cause you to have a VQ mismatch, and your Q is going to be low because you don't have good perfusion in your pulmonary arteries. And you are going to have, like I mentioned, right to left shunting. And that causes you to have a step down or a decrease in your saturations as blue blood from the right side of the heart is going to go into the left side. So as the right ventricle becomes very, very big, it causes a right axis deviation. And one of the classic images you will see on your exam is this boot-shaped heart that is going to be associated with Tetralogy of Fallot. So I want you to kind of look at this chest x-ray and see that you have the left ventricle that is going to kind of go a little bit superiorly towards the base of the heart, and that represents the boot-shaped heart with Tetralogy of Fallot. All right, a child presents with cyanosis. He has a history of 22q11 deletion and an unrepaired heart lesion. Do you see what I'm hinting at here? The parents notice the cyanosis is exacerbated by increased agitation. Which of the following symptoms is the primary driver for repair of this child's heart lesion? A, VSD size, B, degree of tricuspid insufficiency, C, right ventricular outflow tract obstruction, or D, degree of step down of PaO2 due to right to left shunting. What do you think is the answer here? And if you said right ventricular outflow tract obstruction, you're absolutely correct. The degree of pulmonic stenosis is one of the key markers that we look for in Tetralogy of Fallot, because these patients are not going to have adequate pulmonary blood flow if they have very severe pulmonic stenosis. And so that is the key driver for repair. So let's go ahead and talk a little bit about Tetralogy of Fallot spells, or what we call Tet spells. This is when these children in your USMLE questions are going to be very blue. So remember that patients who have Tet spells are going to have hypoxemia and cyanosis secondary to increased pulmonary vascular resistance. Either they have crying, maybe they're anemic, maybe they even have hypotension. All of these are going to increase the pulmonary vascular resistance, and subsequently, you are going to get flow from the right side, blue blood goes to the left side. So what does squatting do? Squatting actually is going to increase the amount of resistance such that now the blood is going to go left to right instead of right to left. And so what is very, very important is that squatting is going to cause you to have an increase, of your systemic vascular resistance. And as you have an increase in your systemic vascular resistance, the blood is not going to go right to left. It is going to go left to right. And subsequently, you're going to get relief of your tetralogy spells. What's high yield for us to know is that you now get, as you're reversing the shunt from left to right due to increased systemic vascular resistance, as you're increasing the shunt from left to right, you are going to have increased P-AO2, as all of this deoxygenated blood is going to go from left ventricle to right ventricle and then into the actual pulmonary outflow tract, i.e. the right ventricular outflow tract, and into the pulmonary arteries. So what's important is that physical exam maneuvers to reverse the shunt are going to be things like squatting, which is basically legs to chest, or administration of morphine. Because when you have administration of morphine, that reduces your pulmonary vascular resistance. That also is going to cause you to have a little bit of opening of the right ventricular outflow tract. And subsequently, blood is going to go into the lungs. So remember that when you're talking about these Tet spells, it is all about balancing your pulmonary vascular resistance, which is very high during times of agitation, for example, and causes these children to have right to left. It's a balance of your pulmonary vascular resistance and your systemic vascular resistance. All right, we have two more topics to talk about, and that is going to be endocarditis as well as rheumatic fever. Let's go through endocarditis. A 50-year-old male presents with 2 weeks of fever and fatigue. The patient is noted to have a mitral valve lesion diagnosed on echocardiography at age 35. The patient presents now with increased CRP, increased ESR, and a blood culture positive for gram-positive cocci that are alpha hemolytic and optochin resistant. Which of the following additional history findings would be present in this patient? A, history of dental procedure, history of peritoneal dialysis, history of BPH, or history of IV drug abuse. What do you all think is the answer here? All right, we have a lot of people saying A or D. Let's go through this question. This patient has the diagnosis of a subacute bacterial endocarditis. So the patient has very indolent symptoms. He has a predisposed valvular lesion, and he has a blood culture that is positive for the viridans strep group, which normally reside in the mouth. And so the answer here is going to be A, history of dental procedure. So when it comes to mitral valve prolapse is actually the most common predisposing lesion in infective endocarditis. So remember that just from a GenPath standpoint, when you have a valve that is going to be damaged or abnormal, such as mitral valve prolapse, bacteria are going to like to stick to that exposed subendothelial collagen and make that dextran biofilm. So this echo is going to show the right atrium here, right ventricle here, left atrium here, and left ventricle here. And as you see, the heart is going to be pumping, and you see the ballooning of that mitral valve into the left atrium. So as the mitral valve has a redundant connective tissue, and during systole, a lot of those mitral valve leaflets will go balloon into the LA. So what is the most common cause of even mitral regurgitation? That is going to be mitral valve prolapse, because the mitral valve has this redundant connective tissue. And so if I wanted to ask you, what makes this mitral valve prolapse murmur louder, i.e. you hear the click a little bit earlier? What makes the mitral valve prolapse murmur louder? Go ahead and put that into the chat. Awesome. If you're saying empty heart, such as Valsalva and standing, you're absolutely correct. Because as you have an empty heart, the ballooning of the mitral valve leaflets is going to occur, and you are going to have increased click, 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 and an increased intensity of the murmur. So when it comes to mitral valve prolapse, it causes mitral regurgitation, and it predisposes patients to infective endocarditis. And what occurs is you have this redundant valve tissue. The mitral valve leaflet bulge into left atrium during systole, and very high yield. In your USMLE questions, if they ask you what disorders may be associated, you can think of or see in the past medical history, Marfan's, Ehlers-Danlos syndrome, and Klinefelter's. And this is all due to defective embryogenesis of mesenchymal cells. So let's go ahead and integrate microbiology. Remember, the big picture here is that subacute bacterial endocarditis, which was in her multiple choice question, usually presents as this indolent symptoms of fever plus a murmur. That's the clinical picture to capture, is fever plus a murmur. Now, the USMLE puts dental procedure, history of mitral valve prolapse, and the clinical picture of fever plus a murmur. And what kind of microbe are they going for here? The viridans streptococci. And remember that the dextrans adhere to the tooth enamel, and you have this fibrin platelet aggregate, and all of this milieu will come onto the valve. What about this one? What if they say the patient has a fever plus a murmur, and they have some abdominal surgery or is on hemodialysis? What kind of microbe are they going for here? Well, they are going for Enterococcus. And Enterococcus is this group D strep. it's catalase negative, and it is going to be a gram-positive cocci in pairs and chains. What about if they have a history of a mechanical valve? Remember that mechanical valves are going to have metal on them. And so maybe they have metal or plastic or some sort of synthetic material, and the patient gets fever plus a murmur, you're going to be thinking about staph epidermidis, very high yield for us to know. So what is the microbiological lab characteristic that differentiates strep viridans and this staph epidermidis? And that is that strep viridans is catalase negative and alpha hemolytic. It can produce that green zone of hemolysis on blood agar, which represents the alpha hemolytic picture. And then finally, staph epidermidis is coagulase negative. And I think that this is extremely high yield for you to know that staph epidermidis is coagulase negative. So whenever you see this coagulase negative staph, you're going to be thinking about staph epidermidis. It could be a blood culture contaminant, or it could be due to the sticky staph epidermidis sticking onto some sort of synthetic material in the body. So whenever you think about bacterial endocarditis, remember the big picture here is that here's your heart, and let's just look at maybe the mitral valve right here. In bacterial endocarditis, you have these bacteria that are going to be adherent to the wall. And when you have the bacteria that is adherent to, for example, the mitral valve, some of that bacteria can drop down and cause you to have bacteremia. So that's why one of the steps in management, when you're thinking about your bacterial endocarditis, one of the steps in management is to grab a blood culture. Because what we are assessing for is, hey, what is that bacteria that is sticking to the valve, and can we capture that in the systemic circulation? So infective endocarditis, let's go through some key elements of pathophysiology. Either you can have local cardiac infiltration, you could have bacteremia, so maybe you have a blood stream infection, and now you have those bacteria that stick right onto the valve itself. You can have vascular phenomena that can be on your exam, or you can have immunologic phenomena. So what are the vascular phenomena? Vascular phenomena are going to be these bacterial emboli, the aneurysms that can occur. You can also have Janeway lesions that are painless. The immunologic phenomena, remember, that is antigen antibody deposits. That can be known as your Osler nodes, as well as your Roth spots that are seen in the retina. So let's go through these gross pathology images here. Here you have the valve that is going to have this vegetative bacterial infiltrates. You're going to have these emboli or aneurysms that can be known as those splinter aneurysms, or the splinter hemorrhages, excuse me. You're going to have the painful Osler nodes at the tips of your fingers and your toes, and then the immunologic deposits of Roth spots. And remember, on your USMLE, watch for fever and a murmur. What you also have to know is that if they give you a patient who is a middle-aged female who has maybe a malar rash and they have fever plus a murmur, or even pericarditis, you're going to be thinking about the Liebman-Sachs endocarditis, which is going to be these sterile vegetations on both sides of the valve, and that is going to be associated with lupus. Okay, very high yield for us to know. All right, let's go ahead and go through some key features of endocarditis. Very nice pathophysiology here. So remember, right-sided endocarditis, for your tricuspid endocarditis or pulmonic endocarditis, you're going to have a patient on your USMLE with history of IV drug abuse, and they can present with shortness of breath, fever, and a tricuspid regurgitation murmur. So right-sided endocarditis, these patients are going to have tricuspid lesions. They are going to have cor pulmonale or right heart failure, and they can get infarcts or septic emboli into the lungs. And I think that this is important because they can put a CT or a chest x-ray that shows these multifocal septic emboli. Left-sided endocarditis, you're going to be thinking about systemic circulation. So those mycotic aneurysms that you can get in the brain or cerebral abscesses. You can get issues with not only the mechanical valves themselves, but also the electrical activity of the heart, which is the conduction defects. You can get septic emboli into the spleen, and you can get these antigen antibody deposits that are going to cause you to have glomerular nephritis. So think about how there's a vegetation on your mitral valve, and bam, that's going to go everywhere in your body and cause you to have bacteremia, leukocytosis or inflammation, and then those splinter hemorrhages, which we talked about as well. So the last portion of what we will be talking about today is going to be rheumatic fever. And this is kind of parallel to infective endocarditis, and I'll get there. But last section of the day, guys, stick with me. I know that this session has a lot of dense material, and I encourage you to continue to revisit it as you repeat these videos over and over again. But for this last section, are you guys ready to finish this webinar? Go ahead and type in yes into the chat box. Stick with me here. All right, Abali's ready. Jerry, Miguel, Vanishka, Elizabeth. All right, thank you guys. Let's go ahead and home stretch rheumatic fever, pictures that you're going to see, physical exam features that you're going to see. Let's hit it with this question right here. A child who has immigrated from West Bengal presents to the pediatrician with fatigue and joint pain. The patient has not had any immunizations or birth records sent to the physician. On exam, the patient has a rumbling diastolic murmur heard best at the apex. The patient has a normal neurological exam. Which of the following mechanisms may be contributing to this pathology? Go ahead and type in what you think the answer is. Awesome. If you're saying B, you are absolutely correct. It's a type 2 hypersensitivity reaction. Remember, molecular mimicry, in which you have an autoimmune reaction. This is going to be the presentation of rheumatic fever. So what we have to recognize with rheumatic fever is that patients usually will be this recently immigrated to the United States. Maybe they have a history of strep infections that are untreated. They may even have this presentation in which they have a abnormal involuntary jerking movement. He's had a history of sore throats, i.e. recurrent strep infections. What is the likely area of the brain which may be affected here? This is an interesting one. And that is going to be your brain parenchyma and specifically basal ganglia. So this is the presentation with these abnormal jerky movements of Sydenham's chorea. And what you have is this autoimmune destruction of the basal ganglia as the immune system reacts with the streptococcal antigen M protein and the brain parenchyma. And this is that process of molecular mimicry, that you have the M protein and your native brain or native tissue essentially being the same in terms of molecular composition. And bam, 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 the immune system starts forming autoantibodies to both normal as well as the M protein. So when we think about rheumatic fever, on your exam, what you have to do is you have to look at the big picture and you have to count out those Jones criteria that you'll see throughout your vignette. The big picture here is that you have antibodies to various proteins and tissues, i.e. the endocardium, the myocardium, and the joints as well as skin. So that's the big picture. And now let's go through the Jones criteria. You typically need two major criteria to clinch the diagnosis of rheumatic fever, acute rheumatic fever. So you have J for joint involvement. The O you can turn into a heart, and you can kind of think of that heart representing the carditis that you could get. For example, you can get myocarditis. N represents these nodules that will be in the subcutaneous space. E represents erythema marginatum. And S, we just talked about Sydenham's chorea. What I want you all to recognize is that the carditis is actually going to be thought of in the rheumatic fever criteria as a pancarditis that can affect the pericardium, the myocardium, or the endocardium. So think about the carditis as maybe causing pericarditis, maybe causing heart failure because the muscle is inflamed, or maybe causing bacterial endocarditis. So let's go ahead and think of this rheumatic fever carditis a little bit more. So let's go into the endocarditis. Remember that the endocarditis of rheumatic fever, you're going to have these uniform, verrucous, sterile vegetations that are going to be right on the valve or the endocardium. For the myocardium, you're going to have those Aschoff bodies, which are going to be these epithelial histiocytes and this degenerated collagen that you will see. And if you zoom in, you can see these Aniskow cells, which represent these enlarged macrophages with this prominent nucleoli. And they kind of look like what they call caterpillar cells. And they can aggregate together and make these Aschoff giant cell bodies. And then finally, you can think of pericarditis. And now pericarditis is going to represent increased amounts of inflammation. Remember that with that inflammation, you get this exudative fluid, and that surrounds the heart. And if you have pericarditis that is going to be long-standing, recurrent, you can get pericardial tamponade, in which you have, see on this echo, fluid surrounding the heart. And that's why you can get things like electrical alternans. You can get cardiac tamponade that presents as JVD, hypotension, and even a narrow pulse pressure with distal heart sounds. So think about the carditis as affecting endocardium, myocardium, and then the pericardium. This is going to be our last slide for today, and we're going to be talking about all the various rashes that start with erythema, just as an integration. But why did we get into this? Well, it's because Jones criteria, the E stands for erythema marginatum. Do you see how there's redness at the margins of this rash? Okay. So where do we see erythema nodosum? We see erythema nodosum in patients who have coccidioides, patients who have IBD, any sort of inflammatory syndrome, and this is going to be typically on the skin. What about erythema multiforme? This is going to be a dusky targetoid rash after some sort of trigger. Erythema marginatum, that's going to be this rheumatic fever stuff we're talking about. Erythema chronicum migrans, where do you think that is going to be seen? Go ahead and type that into the chat box. Erythema chronicum migrans, what is that seen in? Excellent. If you're seeing Borrelia burgdorferi and Lyme disease, you're absolutely correct. And then erythema infectiosum, that's going to be the fifth disease caused by parvovirus B19, erythema infectiosum. And you can see that slap cheek rash as well as fever. All right. Well, thank you so much for joining me today. I do want to just spend a couple minutes going through some important announcements and answering your questions. So please stick with me just for a couple more minutes. I do want to let you know that in our subsequent webinars, we are going to be going through the high yield images and physical exam findings for the various different organ systems. Today, we covered cardiology. I would really, really encourage you to stick around for this special announcement and go to my website, HyGuru.com, and go into my new courses. Now, these brand new releases are just unique courses that I just came out with. The one that I just released yesterday is known as the Study Schedule and Test Taking Strategies for the USMLE course. This course is going to help you build a customizable study plan on Notion, and it is going to bring a one-on-one private tutoring-like experience to the comfort of your own study space as I go through test-taking strategies and how to attack various blocks, various types of questions, and exam day. What's important for us to know in this course is that you get a study plan that you can customize with a guided video right on Notion, and I will activate that as soon as you sign up. I also added an area where you can centralize your UWorld notes. You can tag the organ system, the domain, why you missed it, what kind of questions you're missing, and you can even add the blocks or the title of concepts, etc. This is going to be very, unique and high yield for you. And I do want to let you know that this course goes through various different test taking strategies. How do you go through the graph and charts? How do you go through maybe genetic questions on your USMLE? How do you go through EKG questions on the USMLE? I will be going through the actual strategy, and then we'll break out and do some questions that you can follow along with throughout these videos. This is a very unique way of learning. So essentially, what I want you all to do is not only watch my videos on YouTube, not only do I want you to be productive, but I want you to understand test taking and how questions are written and how to increase your UWorld percentages by applying my signature STEM paraphrase and predict approach. I know I can't work with each and every one of you on a one-on-one basis. So I created these set of videos to really help you optimize your UWorld performance and NBME practice scores so that on exam day, you can crush it. So please sign up on my website. I made it a very fair price, $155. You'll get the study plan, you'll get all the test taking videos, and you will get the handouts to follow along. Please make sure HyGuru.com. Your support means so, so much to me. And that's why I can keep doing these free webinars. It's because students like you support me through these courses and beyond. And I really, really genuinely would appreciate it. Like I said in the beginning of the webinar, if you are going to be gearing up for your USMLE exam upcoming in the next few months or month, please consider enrolling in my second course, which is that USMLE pass-fail course that's different than the test-taking strategies course. It covers the highest yield concepts for your USMLE in a question-based manner mapped to the USMLE content outline. And I hope that this will provide you great value as you move forward. If you sign up today, I will be adding in the subsequent weeks, if you sign up today, I will be adding physiology, immunology, micro, you get it all. You don't have to pay anything additional. It will be added into your course subscription. So please check it out, both the test taking strategies course as well as the pass fail course. So what I want to do is I want to make sure that all of these videos are going to be broken down into small bite-sized pieces for both the pass fail course and test taking strategies course. Give you those handouts so you can follow along on your iPad. And most importantly, with my pass-fail course, ladies and gentlemen, you will get a set of customized UWorld question IDs. So what you will get is a whole document that I made that basically maps my NBME top concepts course and various UWorld question IDs. So you can take these question IDs after you watch the videos and you can copy paste them into making a custom UWorld block, and you can test your knowledge on those specific high yield topics that I go through. So this is such a unique way to learn. And I hope that you join the HyGuru community. Prepare with me. You have the pass fail course. You have the test taking strategies course, which comes with a study plan, or I take a limited amount of students for private tutoring one-on-one. So please visit my website if you are interested in any of this. Again, it's HyGuru.com, HyGuru.com. And most importantly, I just want to say from the bottom of my heart, Happy New Year. Big thank you to each and every one of you. Let's make 2022 big and connect with me and share my stuff on social media. I don't spend any money on social media. I just have word of mouth that carries the mission of HyGuru and this way of preparation going. So share with your friends on Instagram, Reddit, YouTube, email me, email your friends as well. And I will see you in the next webinar. Before you leave, please make sure that you type in one thing that you learned from today's session. If you can type in one thing that you learned, you can then leave. But I encourage you to type in that one thing and then go ahead and send me an email if you have any questions. And I'm going to answer questions in the chat box as well. Thank you guys so much.